you can ask, you can either post your questions in the chat box, or if you wish to interact directly, you can unmute yourself and you can start talking. Both ways, the way you feel comfortable, we are comfortable both ways. So with this, today's session is basically some basic concepts of this questionnaire development or scale development and validation. And today there is only one breakout room where we'll do some activity regarding that, translation and back translation, and developing some items also. And from tomorrow, we'll have like one or two breakout room every day where you can practice. So many of you have submitted a proposal where you need to work on this scale development and validation. And as a part of research, we always plan to do some measurement. So measurement is the basic, rather we can say that backbone of a research. And that measurement, then how we define measurement? Because in this measurement, there can be a very direct measurement and there can be indirect measurements as well. And in measurement, what do we do? Basically, we measure something which varies from one person to another person. That's how we define a variable. So any trait, if you see, no two persons, even the twins, they might be similar into some context, but in many contexts, they are very different. So that's how we say that a variable is a characteristic which varies from person to person. So if we plan to conduct any study, what do? We do and we take some measurement. But what do we measure? So we measure variables. What is a variable? A variable is something which is liable to change, which is alterable, or which is capable of being varied or changed. So in case of scale development, we call these as a construct. So in any individual, we say that there is an uncountable number of variables. And we only measure and count those variables which are needed for our research. So this individual, let's say, has got many variables or many constructs. Like you can see that towards the right side, there is age, gender, and weight. And towards the left side, you can see there's a health, quality of life, and the so this age, gender, and weight. And then towards the left side, you can see there's a health, quality of life, and attitude. So what is the difference between these two sets of variables? Yes, can you please type in the chat box? You are seeing the two types of variables. There is attitude towards something, maybe attitude towards health, blood donation. And then there is a weight, gender, or sex and age. So Dr. Neeraj is writing qualitative and quantitative. Okay, modifiable and non-modifiable. And again, qualitative, discrete and continuous, modifiable and non-modifiable. So in one or the other context, all of you are right. Basically, if you see, all of these are variable, but age, gender, and weight, we can observe it very much directly. So there is something like if you ask the person to stand on a weighing machine, you can measure the weight of the person. So they are clearly defined, and there is an instrument with which we can measure. But if you want to measure health, very difficult. How will you measure? If you want to measure quality of life, it is not something very direct where you can go and measure it in blood or in any sample or through any instrument. Again, attitude, very abstract. So the difference lies in a directly observable, and towards the left side, you can see there is a variable which is not directly observable. So in this, you can see there are 4 variables. There's a pain, height, blood pressure, and SpO2. So can you find the odd pain? Yes, because pain you can see that it is not directly measured through some instrument, whereas the height can be measured with a stadiometer, blood pressure can be measured with a sphygmomanometer. So you all know. Again, the same question. Can you find a odd, this odd one in this? So I will have to see the chat box. Cleanliness. Yes, so you are right. Cleanliness is the different, because amount of biomedical waste generated, that also can be weighed. Surgical gloves use and surgical site infection rate. In this, now in this, vitamin D level. True, agree. So while you were answering these questions, what was the rationale of your answer? So basically, you have thought that there is that in your psychological domain, the process must be going on, that this is a direct measure, and then this we cannot measure it directly. And there is no objective tool. It is largely a subjective one. So can you write in the chat box few other constructs in our healthcare setting, probably related to the work which you are already doing? Yes, all of you, kindly type in the chat box, either on any scale where you are already working, or plan to work, or worked or seen, heard, anything. Quality of sleep, vaccine, hesitancy, good. Menopause rating, okay. Adherence, very true. Job satisfaction, very true. Depression, anxiety, a very well-known construct. So agree. And there are many more. Hesitancy to use certain treatments in medicine, cognitive domain assessment, quality of life. Shraddha is writing. Ferryman Galloway, something wrote some other thing which, okay. Hirsutism scale, good. So you can see there is a wide range of construct in a human, and it depends on your research question or your need. What do you want to measure? This is again like some of all those where you have enumerated. Few more like job satisfaction, you've already told. Quality of life, you've already told. Academic pressure, yes, in MBBS students. How do they perceive it? Attitude for blood donation. So we call, like you have already said, all these are known as constructs, whether it is directly measured or indirectly measured. In this, like you can see, there is a hospital, there is a tangible variable and there is an intangible variable. So there will be a few tangible variable in a hospital and intangible variable. So in a hospital, can you find out an intangible variable? Patient satisfaction, true. Yes, workplace stress, very true. Burnout. Many people are doing now research on burnout. Quality of care, fatigue, pain, emotional quotient, empathy in doctors, OPD waiting time. True. So again, you can see here that number of ultrasound machine, it's a kind of tangible. Cleanliness, obviously it's a little more intangible than, but there is a grade. Cleanliness will be a little difficult to measure as compared to the ultrasound machine number. And then suicidal intent at workplace. Dr. Soni is writing doctor-patient equation. True. So that is also these concepts. If you want to measure, we want something tool or any objective or subjective tool to measure these, because ultimately the whole research is dependent on measurement. And we'll talk about the measurement scale in the later part of the session. So you can see in the list of tangible, you've got equipment, computers, furnitures, buildings, all those infrastructure things. And then if you come to a person like maybe gender, hair color, and if you talk about the intangible variable, then all those, like we could talk of these ATCOM in the MBBS students: attitude, ethics, communication, job satisfaction, treatment response, anxiety. Priyanka is writing professionalism. So all those variables are like, so enthusiasm, interest of medical profession in research. Yes, true, Ria. That is one very important construct to measure in all medical professionals. So now, with all these background of so many variables, tangible, intangible, qualitative, quantitative, and all those nomenclature where you have said like discrete, continuous, etc. So how we define this construct? So there is something known as the construct. So in this scale development, we will be talking about construct instead of variable. Because in the construct, we'll define what is a construct, but variable generally we use where we can directly measure something. Construct is something abstract, which is there in our psychological domain. And we want to measure it through some measurement scale or through some tool. So ultimately, construct is an indicator variable that measures a characteristics or trait. But this construct is not directly observable. That's for sure. If I want to measure attitude, I cannot go and take blood sample and measure cannot measure. That's not the directly observable. That's largely unobservable. That means we cannot observe that variable. We cannot measure that variable directly. And Dr. Neeraj is writing, it is a single variable or a group of variable explaining one entity. Rightly said. And then we will define the difference in the measurement scale. Again, these constructs are defined into two categories. And we'll see in what type of category, how to validate each type of measurement scale. So if I ask you to measure or ask you to write construct in this slide, can you all please do that? What are the constructs and can you identify? What are the constructs? Self-esteem. Okay. Anxiety, depression, fatigue. Priyanka is writing anxiety. Yes. So if you see, everything is a construct, even marriage, tree, everything is a construct. Again, I said there is something known as the directly and something known as the indirectly. So if you see the age, height, and gender, it is a directly measurable construct. If you see the ethnicity, socioeconomic status, quality of life, depression, happiness, anxiety, it is an indirectly measured construct. So in this case, what can you see? There's a person who is measuring the blood pressure. So are you actually measuring the blood pressure or you are seeing the level of mercury? What are you seeing? Yes. So Shraddha is writing, why marriage and gender? Yes, marriage and gender is also a construct. How do you perceive marriage as? Because if you see the traditional definition, now there is a marriage between homosexuals. Now there is a concept of marriage with like people who are just living together, not bounded by law. That is also a concept of marriage. So concept of marriage, this is again a construct, which is different, which varies from person to person. That's why. Coming to gender, again, this is not very simple. If you talk to sociologists, the concept of gender is also not that simple as it looks. Like these days, if you ask someone, not very common in India, but in the Western world, now people identify, they call two types of gender, sex. They say biological and then they say perceived. So there can be a case where the person biologically is a male, but perceive himself or identifies himself as a gender female. And that's why people, they they are getting converted also because they believe, no, I am a biological. So that's why they say that genetically I am a male, but I perceive myself to be a female. So it doesn't look that simple. Like to us, okay, we write male, female. That's simple. But again, but how do we know? We consider ourselves, so somebody has put that in our mind since our birth, that this entity exists. If you have got these structure, or maybe that is defined also biologically. But again, perception and something as a natural, there's a different difference between the two. That's why this marriage and gender, I hope I have made myself clear why this marriage and gender is also a construct. Age, don't you think that age is a construct? If you ask a woman, I'll tell you, in our OPD, no woman is more than 40 years of age. They consider that they cannot go beyond 40. They'll always be less than 40. So either you see with the, what you say, date of birth certificate. But again, age is again, it's a construct. People consider themselves very young, and there are very young people who will consider themselves very old age people, or maybe like they'll see that, no, we don't want to do anything. Maybe I have aged, or maybe my aging has come. And then you may find a person who's 80 years, and then they'll say, no, I can do everything. I'm so young. So again, age is just a number. You must be hearing this from many people. So how that person perceives. So in the construct, in context of construct, it is always the perception in that psychological domain of the person, how that particular variable fits. That's the difference between, and we'll understand this more. This is not the case with the blood pressure. And for blood pressure, it is a measured, but maybe you will see that for many people, this blood pressure is also a construct. What happens when you go, like we go to the field for the undergraduate student cases? The people will say, no, we have stopped taking our blood pressure, medication, because my BP can never shoot. I do exercise this much. So that's a belief that my blood pressure will always be normal. So maybe that's the, you can say the construct regarding the elevation of BP or the existence of this hypertension. So again, that is also the construct. Recently, I met a person who was 45-year-old, and he did some blood glucose measurement. His fasting blood glucose was 375. And the parents were also diabetic. But the person was saying, no, I'm fine. Even if it is 375, I'm not feeling any problem. I cannot have this diabetes. And like for 3-4 days, he did not consult anyone. So that is again regarding that sugar level. That is a construct which is existing in his mind. So again, by setting all these examples, what I want to emphasize, that things which we see that it is very simple, that the blood pressure, if the blood pressure is more than 140, 140, then we'll say hypertension. But if that is so, then we will see there are a lot of other problems in compliance of medicine, understanding the disease. And that's how then came this concept of health literacy. How much people they know about their health. So then you will understand the difference between an objective measurement and how that person perceives that disease to be. So, right. I hope Dr. Shraddha, you are now clear on this. Okay, he has written, yes, okay. So this was, so when you measure this blood pressure, you will see that you are not directly measuring it actually. You are just seeing the mercury level, and it is an indirect way of assessing. Otherwise, you would have put that intra-arterial catheter and measured the pressure. So here the blood pressure is not an observable variable. It is an unobservable variable. And through this mercury height, we are saying that it is an observable, this mercury height is an observable variable. Are you getting this? So this unobservable thing is known as the construct. But in this case, you will see that it very closely corresponds to the blood pressure. This mercury height, or whatever digital, if you are not using a mercury, if you are using a digital, then it is very much closely corresponding to that blood pressure. If I write this statement that the painless killing of a patient suffering from an incurable or painful disease or in an irreversible coma, what meaning are you getting from this sentence? Yes, all of you, please write in the chat box. Yes, true. So euthanasia, all of you are right. Similarly, if I write this, yes, so if you see the definition, this is the definition of marriage by the dictionary, that the formal union of a man and a woman, typically recognized by law, by which they become husband and wife. Again, they have defined this marriage as a man and woman. But nowadays, if you see, there are many cases in the courts where they are trying to define a marriage between two same gender, like all these LGBT community and all. Now there is means that it has been legalized now in India. So again, now that's why the definition of these constructs also keep on changing depending on the time, because measurement is not an absolute thing. Because things are getting changed, that's how the scales or items or definition that also gets changed. So we often refer these constructs, which are the unobservable, as mental abstractions. Why mental abstractions? Because we usually we cannot observe them directly. Like in case of a depression, you cannot, if I'm sitting quiet, or if you're seeing me from a distance, directly, if it is not that severe, you cannot say that, I'm suffering from depression. Or even in case of a suicide, you cannot measure the suicidal intent. I don't know about you people, but we had a experience quite a few times when you are talking to a person who is quite normal during the daytime, and maybe later next day or maybe 2 days after, you are hearing a news that that person did suicide. So just by observing something, you cannot say that that person will go into the self-harm or has got those mood swings or suicidal intent. So constructs are basically very broad. And we can say that we'll see in the steps of scale development that the conceptual clarity of that construct or the defining those constructs, that is the first and foremost task in the process of scale development. Now again, constructs have a varying degree of shades in understanding, in easiness, or in complexity. Some constructs are very easy to understand, like age. Generally, it is easy. Gender, it is easy because it is not putting a pressure on the person thought process. But many times you will see that many constructs like self-esteem. If you ask me 4 or 5 questions regarding my self-esteem, there might be some thought process which will go, and I might take some time to respond to those questions, because those are not often thought of, not as commonly as age and gender. But again, you can see that it has got a shade. So some easy to understand construct to a difficult to understand and measure. So we all know gender versus sex. Gender is basically the role which we play, and sex is the biological as a construct. So in a construct can have more than one meaning. And that's why that pre-testing is very much required. And we'll see what are these pre-testing. So once you have finalized your scale, in your population, how the person is understanding that meaning, that is important. So again, I said that we will use this term construct and variable interchangeably, but I'll try not to use the term variable, because ultimately here we are naming this variable also as a construct. So again, I said that constructs are conceptualized at the theoretical plane. We'll understand what is this theory, but it is not observable. It is an abstract plane, but there are items or there are variables which we select or which we generate so that we can measure this unobservable or abstract. So constructs are lying in an abstract plane. Variables are measured empirically, that means through data, and they are observable. So they are on an observational plane. Like you can see intelligence. Intelligence is a construct. Until now, people are again doing research how to measure intelligence, but IQ score is one variable which measures the intelligence. You can see like weight in kg, weight in pound, that is again directly measured. And then depression, depending on the DAS score or BDI score, that's the depression inventory. You measure based on that score how much depressed the person is. So construct is lying on the theoretical plane. And this concept is important because in the factor analysis, we will again emphasize on this concept regarding the observable and not observable. So then if something is not observable and we have to measure it, how should we turn something abstract into a concrete measurement? So I said that we need to observe few relevant items to measure that variable. How to select those items, that is again, we will be telling you once we move ahead of the session. Or we either measure those directly or we ask from the person indirectly, that means self-report. And most of the time you will see that we use a tool where the person, depending on the literacy of the person, where the person self-report. In this case, like you can see, the first one is the spouse love. If this question I ask from one of the spouse, how many times your partner hugs you in a day? Then this is a direct answer. He might say 1, 2, 3, 4. So this is a direct type of measurement. Again, coming to depression. If I ask, how many times you feel headache in a month? Again, I can say that, okay, once in a week or maybe twice in a week. But if I ask from someone, can you rate your level of anxiety on a 10-point scale? Very difficult, because I'll have to think a lot to answer this question. Because even I might not ever have thought on this item. So it will take some time, some mental processing will go on. I'll think and rethink, and then maybe I'll come to one particular value. Similarly, in case of a hospital cleanliness, if I ask you, what is the number of dustbin in 100 square meter of the area? This is one direct question, directly observable. But if I ask this from a person, how do that person perceive that hospital cleanliness? Then that is very subjective. If you ask from a men and from a women regarding cleanliness, you will find a lot of difference. That for a woman, everything seems to be, like clumsy or dirty. And for men, generally, I'm not gender biased, but generally, they'll think everything is okay. It seems okay. So again, that is a little bit of abstract concept. Similarly, patient satisfaction. If you have come up to a hospital with very less of expectation, you may be more satisfied. So again, that is not a very direct question. So any question where you have to put a lot of thought process in answering that question, that is not a direct question. That is an indirect question. And we will see most of the time in scale development and scale validation, it's the indirect question which generally we ask. It's not the general questions. So what do you think? That can we measure any abstract variable by a single item or single observation? Yes. What is your opinion? All of you, please answer. No. Dr. Priyanka is writing no. Dr. Poonam is also writing no. So since like for blood pressure also, for direct measurement also, generally we say that you should take 3 measurement or at least take mean of 2 so that it will reduce the intra-observer bias or maybe some other error if it is there due to machine or maybe due to the person. But in case of an abstract concept or unobservable variable, generally we can never measure that with a single item. So we need multiple items to measure that particular construct. And that number might vary from as less as 4 as high as 100. So maybe I have selected 20 such items to measure my abstract variable. And again, I may take an expert opinion in framing that item. So it may be possible that I have thought that a particular item is measuring a particular construct. But actually in population, it's not the same thing which I am thinking. So let's understand this. Because a construct has got many domains. In case of love, if I ask you to define love, to give the operational definition of love, it is not that easy concept. Because love has got many domains. It can be love for different relationship. Love can be expressed as care. Someone might say that if person is caring, he is loving. Some might say, spouse, that if he respects me, he loves me. Female might say that if there is a faith, there is a love. So it's, again, there's a too many domains of a particular construct. Similarly, if you talk about depression, depression can be there in the professional life or in the personal life, daily activity. So the items measuring the depression in day-to-day activity and in professional activity would be different. It will not be the same. Similarly, if I want to measure hospital cleanliness, the staff attitude or the this biomedical waste management training, there are the other dimensions. So we agree that for any construct or any abstract variable, different researcher might be having different items and different number of items. I might take 7, somebody might take 12 or 20 and so on. So like if I wish to measure the patient satisfaction of a hospital X, so I've gone through hospital records to get the patient satisfaction item. And most of the items were related to the hospital cleanliness. So I just decide to use these items to develop a scale to measure patient satisfaction level. So is this approach justified? Through records, I'll just repeat, through records, I tried to get some patient satisfaction items, and through records, I got the items which were related to the hospital cleanliness. So yes, you people are writing no, very true. Because then my construct will be cleanliness. It cannot be satisfaction. So the earlier approach was not justified. And how it was not justified, that we'll see. So now there is something known as the measurement model. And this is really, really important for all of you to understand. What is a measurement model? Because there are two, on day 3, we'll do the factor analysis. And on day 4, we'll do the confirmatory factor analysis. That is the exploratory factor and the confirmatory factor. There also you will see a lot of use of this concept of measurement model. I'll repeat this again during day 3 and 4, but I will try to explain it simply now. So measurement, I said that it is a changing concept. Let's say for marriage. Initially it was, definition was given something else, and now some other definition is trying to be developed. So measurement is never static, it is always a dynamic thing. So again, like if someone asks your age and gender, it is very easy for us to answer. And only through a single answer, we can say usually. So these variables are linked to the relatively unambiguous characteristics like morphology or events like date of birth. But if someone asks about our ethnicity, so this single question is not sufficient to answer because it's a more complex. If you ask about my ethnicity, it involves a combination of physical, cultural, and the historical perspective. Similarly, if there is a person who is suffering from the cancer, then if you ask how they are feeling about the quality of life, then you can't measure this with the single item. So now there is something known as the index and there is something known as the scale. And there is a difference between the two. And all of you, please go back today and see your tool. Is your tool is a multi-item measure or it is a scale? Because you need to identify between these two. Then only you can perform the reliability and validity studies and do the factor analysis and the exploratory, the principal component as well as the confirmatory. So identifying your scale, that means identification of your construct, that is the most important backbone of forming the whole research or carrying out the whole research. So please focus a few minutes on this. So what is a scale? So scale is basically, in scale, it has got a single construct and there is a linkage between the items and construct which we are measuring. But in case of a multi-item measure, there is no such causal linkage between the questions and the construct which we are measuring. Generally, I should not be saying no, I can say the very less. For example, look at this multi-item measure. This I am seeing as a multi-item. So remember, I am saying two things, a scale or a multi-item measure, right? So look at this multi-item measure. Yes, can one of you please read this? Yes, I can see Sana. Sana, can you read this all variable?
Yes, ma'am. So, looks at multi-item measures. And the first question is, what is your age? The response is 32 years. Then it asks for gender. The response is male. What is your occupation? Businessman. What is your qualification? Graduate. What is your religion? Hindu. Where do you reside? In an urban area.
Okay, thank you. So Rimi, can you give a common heading for all these variables? Or maybe Sana, you can, since you are reading this, I don't know whether Rimi...
They are asking for the socio-demographic information.
Okay, yes, Dr. Poonam and Dr. Neeraj, Priya, Bansal, they are writing socio-demographic profile. So in this, is this age, there is a cause, is there any causal linkage between age and gender? Or occupation and qualification? Or religion and residence? Are any of these questions are causally linked to each other? So most of you are writing no. Yes, to some extent, like occupation and income, maybe you can correlate. But again, that is not true because occupation and income, again, there can be wide variation. So this is a socio-demographic variable. So can you call socio-demographic variable as a scale or as a multi-item index? What will you call? Yes? Sana?
We'll call it a multi-item index.
Multi-item. So although we write the socio-demographic scale that you will often hear, like Kuppuswamy scale, Uday Parikh scale. So we write scale word to it, but actually it is not a scale because to define a scale, it should be a single construct or the different domains of a construct and the items should be related to each other, right? Here you will see that items are, so that's the very, because in the previous workshops also, like people, there was one faculty who was doing a project on knowledge regarding the use of insulin in the diabetic patients. So he had got multiple items, right? Like how do they preserve the insulin, or probably how do they take, like morning, evening, when they fly to some other area, how do they keep at home, how do they keep. So there was a lot of questions. So, and then there was a few other items also. So now you need to identify whether it is a multi-item measure or it is the single construct which you are trying to measure through various items, right? Many times it is not that easy to identify. So you may need to consult experts also, whether it is a theoretical construct or it is a multi-item measure. Like in this case, this is also one thing. Yes, someone else can read. I can see Dr. Samina. Can you read this?
Yes, ma'am. Look at this multi-item measures. The variable is appearance, that is skin color. It is response is pink. Then second variable is pulse. The response is
It's a wrong response actually. It should be like
male.
92 per minute. It's male. By mistake, it's written.
Then grimace is there. Then prompt response to stimulation. Then activity, active. Then respiration, it is vigorous cry.
So can you name all these variables into one?
It is Apgar score.
Very true. It's a Apgar score. But do you think that are these items are related to each other?
No.
Generally, maybe it may or it may not. Because if you see, there can be a case where pulse is there, but appearance, because there are shades. Again, this reflects. That's why we have got like, we define like if it is less than this. Similarly, if you see Glasgow Coma Scale. So Glasgow Coma Scale is also, the items are there. If you see that obviously there is something which is controlling each of these activity. So there is some form of linkage. But if you talk about a construct, then it is not a single construct which it is measuring. It is a multi-item. So it is again a multi-item measure. So in the previous two examples, what we have seen, that the variables, item or questions, they are not the result of any one thing. That means they are not identifying a single construct, but we have grouped the different variables or items or questions under a common category. And that does not imply that there is a causal linkage. So more general form for collection of such items that we might aggregate into a composite score, this is known as index or emergent variable. There are two terms. So most of the time you will find index word as a commonly used word, but the collection of items into a one composite score is known as the index. Now look at these variables. Yes. Can someone else read this? Maybe I can see Ananya. Dr. Ananya.
Yes, ma'am.
Can you read this?
Yes, ma'am, of course. Variables, I feel sad and low most of the time. I feel disinterested in things that earlier seemed pleasurable most of the time. I feel I should be or I am being punished some of the times. I feel guilty most of the time. I feel difficulty making decision most of the time.
So can you anticipate what these items should measure? Anything?
It is about mental health or depression.
Yes, agreed. So now if you see the previous scale, this one, and if
Yes,
you see this scale, so what is the difference which you can see?
ma'am, I think the previous scale, the variables are not related to each other. Here, the variables are related to each other. Like it is all about our questions are all about the mental health perspectives.
Yes. So you can see that it is only measuring a single construct, whereas
Yes.
If you go here, there is an occupation, there is a qualification, education, there's a religion, age. So there are many constructs. It is not a single construct. But if you come here, it is a single construct and all items are measuring that construct. So
Yes,
can
ma'am.
all of you see the difference between these two? Am I making sense to all of you?
Yes, ma'am.
Okay, thank you. Dr. Poonam, Priyanka, Supriya is writing depression. Okay, so true. So now if you got this, in this example, so already Ananya has said that they are the result of one construct and that imply that there is a relationship between the two. So that's how we define the theoretical versus atheoretical construct. So what is a theoretical construct and what is a atheoretical construct? So before I go, do you people need a break of like 5 minutes? Because in our feedback session, one of the participants said that there should be break after, okay, it's not 1 hour. Okay, if not, then it is, if Dr. Poonam is writing yes, Dr. Vikram is also writing yes. So there is so 2 minutes break. I'm here waiting for all of you. You can go like have water or if you want to go to your natural calls and then again you can come back. In the meantime, those of you who wants to stay and ask some questions, you may ask. Okay, so doctors, Rajiv is asking, so if the items are related, then it's scale. And if item or questions are not related, then it is multi-item. Yes, I'm not saying that they are not related at all, but the relationship, if you see, we'll see in the correlation, it is very less. As you might say, like I have said that socio-demographic scale is not a scale, rather it's an index. But many people, they say no, there is a relationship between the occupation and income. If the occupation is like somebody is having in a good occupation, the income will generally be high. Agree. But then each of the items will not be related. First thing. Second thing, index generally have more than one construct. Like, let's say the simple example, socio-demographic variable. It has got maybe the age, maybe not, then your income. Generally, we say income, occupation, and this education. So it has got more than one construct. All these three constructs are different. Whereas in case of a scale, generally it is one broad domain or one broad construct, and then it is broken down into different factors. Because like we said about love, So love can be there for spouse, love can be there for kids, love can be there for maybe colleague, but love will be there. So similarly, but if you talk about like any other, I'm not able to give you the example of that multi-item index, but like many times you measure that there's a CAP questionnaire, knowledge, attitude, practice. You are measuring something. So there, that knowledge and maybe practice, although it is related to that one particular topic, but it is not a construct in that, and there are many different contexts in which you are asking the questions. So that's how we don't say that items are not related at all, but it is very indirectly, or we can say directly in one instance, it seems to be not very much related. Then if items are not related, then it is a multi-item. That means it is an index. It's not a scale. For a scale, it should be, all the items should be related to each other. And that's the test which we do. You will see in exploratory factor analysis, you see all the correlations between the items. And if a particular item has got a very less correlation, then generally what you do, you remove that. Okay. So that's how you define the multi-item versus a scale item. So CAP is a construct about CAP about what? So generally, knowledge, attitude, practice, you can say definitely it's a construct. Everything is a construct. That's how we discussed. That even the level of amino acid in our body is a construct. But there is something known as the directly observed. And there is something known as the not directly observed. So if you see practice is a directly observed. I mean, you can ask questions whether you do it or not. And then again, there is one more difference between this multi-item index and the scale. In scale, you have got the same sort of response. Like if I want to measure something, and it should be 5-item scale for all the items. Whereas in case of a multi-item, it may not be true. For knowledge, you can only ask like yes and no. But for attitude, you can ask like maybe agree, slightly agree, not agree at all. So for one construct, you may have a Likert scale. And for one construct, you may have a yes-no. Okay. So that's the difference. Even the response or the response of the items is same in case of a scale. It may vary for a multi-item, because I said that multi-item has got many constructs. It is not only a single construct. So I hope you are clear now, Dr. Sathya and Dr. Rajiv.
Yes, ma'am. Thank you.
Okay. So I think 2 minutes are over. So should we start? Dr. Shraddha, did you get the answer of your question regarding CAP? Okay, thank you. So now understanding the theoretical versus atheoretical construct. So what is a theory? So generally in qualitative also, we always talk of some existing theory or existing theoretical perspective or the finding answer of some particular phenomena and linking it to the theory. Because if you see largely all human behavior, whether it is a social behavior or a personal behavior, largely it's a behavior. And all our behavior are determined by our theoretical perspective. There's a theoretical construct. So what is a theory? Basically, any set of ideas or a single idea that is trying to explain something. So during our 10th and +2, we all had exposure regarding the various theory. In case of a physics, there's an atomic theory. There's a theory of relativity, which was given by Einstein. In biology, if you say there is a cell theory, there is a Mendelian theory, there is a Darwinian theory, there's a theory of evolution. If you see the chemistry, there's a kinetic theory of gas, there is a valence bond theory. So you have got a very nice exposure. We have got, rather not we all have got a nice exposure of all these theoretical concepts during the 10th and +2. Now coming to health. there are a lot of theories which are now trying to explain these health behavior also. In case of we always read this, health belief model or change theory, or why a particular thing, like maybe there are many psychological theory, there is a critical race theory, there are many social theories, organizational theories, economic theories, educational theories. So if you see, many of our behavior, it is largely linked to some theories which are already existing. And sociologists and psychologists, they always go, whenever they try to develop some scale, or even if they try to modify some scale, they always take help of these people who are theorists, or maybe you can review the literature. So these theoretical framework, it provides a particular perspective or lens through which we can examine a topic. Coming to theoretical versus atheoretical measure. So now this is also one difference between a scale and a multi-item. So a scale will always have a theoretical perspective or theoretical background, but a multi-item measure will not. So again, I have discussed about this age and gender of the person. If I ask this question assessment of, like, if I want to know about the meal preferences from the hospital patients, will it be a theoretical or a atheoretical construct? All of you, please answer. I'm talking largely. I'm not saying that it will not have any theoretical, but largely whether it will be atheoretical or theoretical. So Dr. Poonam is writing atheoretical. True. Agree. If I ask this question, or if I want to take public opinion, whom they vote? This is a very common question during the exit poll or during just before elections. Whom should we vote? What do you think? It is a theoretical or a atheoretical? Atheoretical. Now again, if I ask this question of public opinion as this, how attitude towards a specific issue affects candidate preference? If my research question is this, whether I am tapping a theoretical construct or a atheoretical construct. A theoretical construct. So now you can see a little, now you can differentiate a little bit between what will be a atheoretical construct and what will be a theoretical. Again, all are constructs, that I agree. Everything is a construct, like we have named variable as a construct during these sessions. So all are construct, but there is some theoretical construct and there is some atheoretical constructs. So atheoretical constructs, if I want to differentiate between two, I will not take much of the time in responding that atheoretical construct, because it doesn't incite my theoretical domain and my psychological domain. It doesn't pressurize me or force me to think. And I'm quite tuned to answer those questions. So that's how that is little superficial, you can say. So that's why it is atheoretical. Again, coming to theoretical, it digs more into our psychological domain, and it is largely unobservable, and it generally measured on a Likert scale. So distinguishing between theoretical and theoretical measurement, it is not always easy. Sometimes it is difficult. So you may need to take an expert opinion if you want a very clear cut, because even if you take expert opinion, there might be a few experts which will say it is largely atheoretical. So then you may take a decision regarding like majority, what majority is saying, whether it is a theoretical or atheoretical, and then you may decide, because all your validation of scale and doing the exploratory factor and confirmatory factor analysis, it will be largely dependent whether your scale is a atheoretical or whether your construct, not scale, your construct is a atheoretical or a theoretical. So am I making sense to all of you up till this point? Okay, so Dr. Poonam is saying yes. Ananya, Supriya. Yes, okay. So Samina is also saying yes. Priya, yes. Okay. Thank you so much. Sana is also so many yes. Now, from here, we'll see the measurement model. Remember, I talked about there is something known as the measurement model. Because in all these exploratory factor analysis, you might be hearing these terms. I don't know whether you are familiar or not, but you will be familiar after 4 days. So all these analysis like exploratory factor analysis, confirmatory factor analysis, these are the terms which are based on the measurement model. So that's why the concept of measurement model is very necessary for interpreting those results. That's why please pay attention. So I said initially that construct is an abstract idea which exists in our mind, and we measure construct with the help of items. So can you tell that which comes first? Whether it is the construct which comes first or whether it is the item which comes first? Construct. So true, construct is there in our mind. Item we have devised. Now coming to the type of measurement model. So in the first one, in this diagram, you can see the construct. Yes, Dr. Poonam is writing both ways, true. So construct is affecting the items. There can be one thing that you have identified items, and when the construct is changing from one person to another person, the items are changing. Here the construct is the variable and items are the measured. So these items are observed and this construct are not observed. Here also this construct is not observed, but here the items are affecting the construct. So now we'll see the first type of model where the construct is affecting the item. It is known as the reflective model. And the second type where the construct is getting affected by the item, it is known as the causal formative model. Is it clear? It will be more clear when I'll repeat it many times. But till now, I have talked about two measurement model. The first one is a reflective model. Why it is reflective? Because in both the cases, observed is the item. So the construct is getting reflected in the item. That's why it is known as the reflective. And in this case, items are determining this construct. So it is the causal formative. So if I ask like this question, if health is considered as a reflective construct, then we may say that health is good when the blood pressure is normal, sugar is normal. We go and get our health checkup done. So how do we decide that if these variables are okay, our health will be okay? So these are just a reflection of our good health. Now again, if I consider health as a causal formative construct, I may say that if I do regular exercise, if I take balanced diet, if I sleep for adequate time, then they are causing a good health. So now coming to this reflective model. So again, there are two types of model. There's a reflective model and there is a causal formative model. In a reflective model, the construct is getting reflected through the items. In case of a reflective model, can I say that health as a construct can explain 100% of the variation in BP? Can you all say? Right, yes or no? Yes, very true. Answer is no. Why? Because the blood pressure may be affected by many other things. It may be season. It may be some mental, like health is a broad one. Which type of health I'm talking? So it might get affected by some other variation, and that is known as the error. So what is the error? Now I have started talking in terms of statistics. Till now, I was talking only in terms of the conceptual qualitative perspective, you can say. But the moment I start talking about this error, you should realize that now I have started talking about something related to statistics. Because this error, we always talk of these error into the statistics. So the amount of unexplained variation in this blood pressure, that is known as the error. Now, a typical reflective model will look like this. So please pay attention here. Right now, you think that there is a one big construct, and they are the two domains of that construct. And these Y1, Y2, Y3, these are the three items which are getting affected by this factor 1. Similarly, this Y4, Y5, Y6, these are the items which were getting affected by this factor 2. So the direction of arrow, you will see it is from this construct to the item. And these are the error term. Error 1, 2, 3, 4, 5. Can you see this? Now, you have to see that error, the direction of error is different. Error is towards this, and this is also towards this. So this is the typical reflective model where each error is associated with item, and error are unique. Error are all unique. But you will see they are common. This factor is common to Y1, Y2, Y3. And this factor 2 is common to Y4, Y5, and Y6. But these errors are unique. They are not related to each other. So this is known as the reflective model. And here the measurement of error is at each item level. Have you understood this? I'll explain this many times, but till now, have you understood regarding how a reflective model looks like? What is the direction of error? What is the direction of item? How it is related to the underlying construct? So can you repeat? Yes, I will definitely repeat. Right now, actually, what should I have done? I should have taken this as a real life example. And this we will see later also. So maybe like just you see that there's a depression, which is the underlying construct, and there is a two factor of these depression. Okay, these two factor can be depression at workplace and depression at personal life. Okay, these are the two different domain of that depression. So I have taken 3 items for this first domain and 3 items for the second domain. So if my model is a reflective model, so what will happen that these items, they will be getting affected by this factor because this is unobserved. This factor is unobserved, and through these items, I am measuring these unobserved thing. So the direction of arrow will be from this factor to this item. That's the reflective model. And error will be unique to each item. But this factor will be common to all these items. So you can see that Y1, Y2, Y3, if these 3 items I have chosen to measure this depression, maybe at workplace and depression at, you can say at home, then these will be common with all these 3. But this error is not common. I have not done like one error and then connected to each and every one. So error are unique, but the factor is common. This is known as the typical measurement model, which is a reflective in nature. And you can say that the direction of causality is from construct to measure, and the measurement error is at each item level. And the items are highly correlated. So Ananya, have you understood this? I'll repeat this many times, don't worry. But now have you understood this? Okay. Now coming to formative model. So formative model, we say that can I say that the exercise, diet and sleep can explain 100% variation? Again, we will say no. But in the case of a formative model, the error will be at the level of factor. You can see this is the error level. So this error is at the level of composite factor. And the direction of arrow is from this item towards the factor, because we are saying it is causal in nature. That means this item is affecting this composite factor. This item is called this composite factor. So remember, we talked about that multi-item and we talked about that scale. So generally, even if there is a similarity, and if you see this, these items will not be very much highly correlated. There will be very less correlation. So remember, we were talking about that multi-item or index measurement versus measurement, that is the scale. So that generally that scale or construct, if there is a theoretical perspective or that construct is theoretical, it will be like a reflective, like this one. Okay. If it is a multi-item, it will be like this one, which will be like causal formative. And in that, measurement will be at the level of the, you can say, factor level, not at the item level. So have you understood this, or should I repeat this? I cannot see any other message. Are you asking me to repeat? Okay. So have you understood this? Then I'll go ahead. So these two are very important for you to understand. And remember, we have talked since beginning regarding the index or emergent variable versus scale. So generally a scale, all that, yes, I'll give you the example. Don't worry. Dr. Neeraj is asking how these factor 1 and 2 are correlated. We'll see this. Till now, only remember the fact. Okay. When we'll do the factor analysis, we'll see each and every item, how it will be related. But I want you people to remember this fact for now. We will test these facts when we'll go to the analysis. Okay. And I'll repeat that many times, this concept many times, so that it will be embedded in your brain regarding this reflective one, this one. So we will focus on this one, this reflective model, because we are focusing on scale validation. We will briefly talk about the multi-item measure also, like what kind of validity and reliability studies we can do on the multi-item measure also. Okay, but largely we will focus on a scale or the construct measurement that is a theoretical in nature. So now coming to the steps in the scale development. What are the various steps in the scale development? And how we perform the translation and the validation studies. So yes, now focus on this for a few minutes. So first, all of you, I have asked all of you to go back today and identify, or many of you know what is the construct which you have to measure. First, what you do, you review the literature and you see what are these scales which are available in the clinical. And many times we have shared two books with you. One is of a SAGE publication, which is of Robert, and the other is of Norman. These two textbooks, and we have made all our content taking reference of those two books. So you can go through those two books also in case if something you need clarification. And this diagram we have taken from Norman, which is a health measurement scale book. So what he suggests, that it is very rare that you are defining something which is not defined earlier. So generally, maybe not health. That particular construct is already there, maybe in psychology, maybe in sociology, maybe in education sector, maybe in anthropology. So somewhere it must have been defined. So what generally you should do, because it is not very easy to develop a scale since scratch. You can develop a questionnaire, definitely, that multi-item index. That can be done. But developing a scale is not a very easy process. And we will share articles also with you. There is a health literacy scale development process. where the person has developed that scale. And I think there's a PHQ-9 development story also. So you can go through those literature, and then you can realize that it is a very intensive process, development of a scale. It involves a lot of qualitative skills, qualitative research, as well as this quantitative. So what we prefer and what we ask our students to do, that if there is already any existing scale, is there or not, maybe in different branches. And if there are more than one scale, then you may select items from those scales. So already there is an existing item. If you are having a construct which is very similar, you can select those items. That means you can modify it. So ultimately, what are you doing? You are modifying it. Modifying, how you can modify? You can change language little bit. You can remove questions which are, you are thinking that it will not be relevant to your population. A scale which is developed in London or scale which is developed in Sweden, if I want to use that scale in Bihar, I don't know how it will be done. So it is not very relevant also, but again, I can modify that. So it is always advisable to take reference of the existing scales, to take items from those scales, and then modify that scale and use that. So if it is already there, so has it been used in the same comparable population or not? So from now, I'll go to this arrow. So if there is a scale, then I will go towards this direction. I'll use with this comparable group. If it has not been done, then I'll do a study with a sample from the target population. And then if the results are suggesting that the instrument is appropriate, then I'll go with the reliability and the generalizability studies. If not, then I'll go to this generation of items. If there is a no existing scale, like in this case, you can see that there is no scale. So what you can do, then there will be a process of generation of items. And we'll discuss this also. And in generation of items, we take help of experts, the patients, clinicians, and we do a lot of qualitative data collection technique, like key informant interview, in-depth interview, and the clinical observation. And then we develop item. And after we have developed item, then what we do, one arrow is missing here. When we see about the revision of these items, and then we do the reliability, generalizability, and validity studies. If there is some revision required, we again go back, revise, and then we again generate it. So this is how we try. So in this workshop, our focus is to do a basically existing scale, which we can modify. We can pilot test and pre-test that, and then we can do the reliability, generalizability, and validity studies. So Shraddha is asking, is reliability comes first and then validity? Actually, reliability we do twice. First, we do before, like in the beginning of factor analysis. Once we have done the factor analysis, then we again do the reliability. So reliability we do twice. So I should not say that it should come before validity, because it comes before and then after validity also. Although it is not written here, but you will see the process that we do the reliability testing twice. Because in reliability, we'll discuss that initially we don't know regarding the dimension. So the reliability scale which we have, that is the Cronbach alpha, which is the most commonly done, that is a unidimensional. So we'll discuss these concepts, Dr. Shraddha. But you can say that reliability, it comes, we do it along with validity. And once we are done with the factor analysis, and we are sure that our construct is breaking down into one factor or many factor, depending on that, we again repeat reliability. Okay. So this is one which I wanted you to say. And we just want to say that if there is an existing scale already,
Sample size. Can you meet me tomorrow and Wednesday? Tomorrow is Wednesday between 9 to 1. 2 to 5, I have sessions to attend. 9 to 1 in attend. Or you just what?
let me see if somebody is talking. Okay, so I think. So now we can go ahead. So now coming to what is a scale. So basically scale is a set of items which is designed to measure a construct, which is also known as the latent variable. So this is also known as a latent variable because this is not a directly observable variable. So again, to measure any construct of interest, like we have said, that you have to go for a standardized questionnaire first and then think of developing a new scale. So first step is to identify the construct of interest. So those of you who are already doing some research activity or submitted any research, can you all write what construct are you measuring in your research? Okay, so Shraddha is writing PHQ 9. Jyotika is writing reproductive health. Vitamin D level in COVID. Okay. Happiness index. Domestic violence. Okay. So all of you, those who have typed, can you go back? Go to the Google. Vaccine hesitancy, infection prevention, adherence to treatment, hesitancy to use helmet. So all of you, those of you who have typed, please go back to Google and write scale to measure and then underscore and the construct of interest. Please write that and search. Are you able to find any scale? GAD, generalized anxiety disorder. Dr. Neeraj is writing. Shiva Santosh is also writing, translating readiness to change. Yes? All of you, please type in the chat box. Did you get it? Yes or no? There it is showing battery is running low. Supriya is writing yes. Satyanand, yes. Parul is writing yes. So practically, if you will see, maybe not you will find some related thing, maybe few items, not exactly like you. It may be paid or you may need to take permission from the person, but you will find some scale because it is said that if you thought of something which is entirely new, that is very theoretically challenging because in some domain of science, it must have been developed. So that's why we say, rather than going and developing something new, you should try to modify the existing one. So if that scale is there, so first thing, maybe if it has been tested in your population, but if you want to administer it as a self-administered scale, so you need to do a translation. So now we'll see one activity regarding translation. So a validated scale, which is already validated and in the same population, and if that it is related to our construct of interest, if it is available in the native language, then we directly go with the validation and reliability studies. If it is in another language, then we should translate the scale. So this translation is again, it is an iterative process. It is not done in a single go. It might take 3, 4 5 cycles. So how to do that? First, you have to establish an expert committee. Now, what do you mean by expert committee? So in this expert committee, generally you should have one language expert, one subject expert, and then if at all, if you have got a person who is maybe a representative of a patient and who should be like having a both language proficiency. So ideally patient we take during the pre-testing stage. In this case, you can only go with the subject expert and a language expert, but they should have a proficiency of language. So what is the, and again, there is a separate committee for the forward translation, and there is a separate set of people for the backward translation. So now what do you understand by forward translation? In forward translation, if you've got a tool, like if it is in English, then those of you who are in, all of us have got many languages in India. So that's one exercise also which you people did. You have done the forward translation of a quality of life question. So from English to local language, that's the first thing. That we known as the forward translation. Not local to English, rather it is English to local, because most of the scale which are available, because English is an international language, so that is in English. You need to translate it into your local language. That is known as the forward translation. And then it's written here other languages. Maybe if it is in Spanish, but again, you need to do it in the native language. And then there is something known as the backward translation. So for backward translation, so there are two different expert team for the forward and the backward translation. The backward translation will be like from native language to the English. And then you see the initial two, whether they are similar or not. So this you people have done. We have sent this to you. And this question, to what extent do you feel that the physical pain prevents you from doing what you need to do? And these are the 5 items Likert scale, 5-point Likert scale. Not at all. So this, I think two of you have like responded in the terms of these moderate and great deal, where the activity was to tell. So if I show you that Google sheet, let me show you. Yes, I know that. Let me see them. So I think it is not there. Yes. Yes, so can you see this? So you all have responded in this Google sheet. And Dr. Naveen, can you share this sheet to all the participants? It's shared on the WhatsApp also.
Yes, ma'am. Yes, ma'am.
So you can see that there are people, like 4 people in Bengali, like Jyotika, Paramita, Devjani, and Ananya. So what you can do the reverse of its back translation. So like Ananya can do Devjani's back translation and Devjani can do Ananya. Similarly, the Jyotika and Paramita, you can exchange in between. So what you have to do the back translation to English. Okay, in English language. Similarly, if I go to Hindi, Malayalam also there are 2 people I can see, Kartika and Dhanya. So you can again do the back translation of each other. Or you can write in the chat box also. And then I can see Nipun Jot in Punjabi. And Punjabi, I can see who else in Punjabi? Adarsh Jot. You can do the Nipun Jot ka back translation. And then I can see in Hindi there are many, like Dr. Devanand is there, Dr. Parul, Swati, Ashish, Samina. So what you can do, Ashish can do Samina's and Samina can do the back translation of Ashish. Similarly, Parul and Swati can interchange. Then you can write in the chat box also. Then I can see Dr. Keshav in Marathi and I can see Dr. Shraddha. Although Dr. Shraddha has not written the translated, she has not translated actually. Actually, Dr. Shraddha, Dr. Devanand and Dr. Priyanka, you have given the score to it like 4, 3 and 1. You have what you have thought that you have to like give a score and response out of it. Ideally, it should have been the forward translation. So never mind. So what Dr. Shraddha can do, you can do the back translation of Dr. Keshav, or Dr. Keshav has also written totally. So maybe that we cannot achieve. In Tamil, I can see Dr. Vijay. And Tamil, I think there is no other person. Anyone in the group right now who understands and knows well Tamil, then please do this Dr. Vijay's back translation of this question. Similarly, I can see Telugu, Dr. Chandrasekhar, and Dr. Rajiv has written in Malayalam. So anyone in the group who knows Malayalam and Telugu, you can please do the back translation. So Dr. Paramita is writing how much. So let us see from the beginning. Na? Dr. Neeraj has written, yeah. आपको किस हद तक महसूस करते हैं कि शारीरिक दर्द आपको हुआ? So to what extent you feel that the body pain restrict you from doing the work which is essential for you? And if I see the original question, it's written to what extent you feel that the physical pain. So now there is a difference between the physical pain and body pain. Prevents you or restricts you. So these are the two different words. Again, we can take it as it is from the doing the work which is essential to you. So what you need to do or which is essential. So there's a difference between the two, which is essential to you and what you need to do. The underlying concept is different between these two items. Difference is need and essential. So again, you need to define. So this is one iteration. Again, you can get like second time, third time, because I can say that this is not the perfect translate, because the back translation should match with the initial one, but it is not matching. Dr. Paramita is writing, how much do you feel physical pain hampers doing whatever you want to do? Yes, maybe that is a better one than the first one. Dr. Satyanand is writing, so I want some English. So Ashish is writing, what do you feel how body pain interferes with the work you want to do? Okay. So what do you feel means extent that it's not written. What do you feel it's written? So to what extent that was the, so Dr. Nipun Jot is rightly writing, to what extent do you feel physical pain? It's exactly that English one is there. Jyotika, can you send the Excel link again? Okay, Naveen, you can see to it. Dr. Adarsh Jot is writing, till what extent do you feel? Can you go up? Yes. Till what extent do you feel that bodily pain does not let you do that which is necessary for you to do? Okay, this is again, so you can see essential for you, necessary for you, what you want to do, and in this case, what you need to do. So there are many versions which are coming. So how does your physical pain? So again, you can see that we should always, in this language person who is proficient in both the language, that is needed, because he will make us understand along with the technical person, definitely, because technical person will give input on the technical content, and language person maybe as a lay person, not as a lay, means how the common people understands that will tell you. So this was one of the activity, and you all have seen that it's a iterative process. This is one cycle you did. If it is not perfect in the first cycle, you might again try like second or third cycle to make a perfect of this Hindi, and then you will go for the pre-testing that we'll discuss. So now coming back again to this. So I was talking about I have introduced two terms, the pre-testing and the pilot testing. So now many people, they get confused, and initially we were also not very clear, like what we were understanding, that was entirely different from what the SAGE or from the standard textbook, what they say. So that's why we want to clarify the concepts on pre-test, difference between pre-testing and pilot testing. So coming to this pre-testing. So why do we do this pre-testing? So I said that there should be some patience also. Once you have finalized, like you have taken the items and you have translated the scale. Now you want to pre-test that. So pre-testing is basically done to reduce the measurement error and to reduce the respondent burden. That means, is there any problem with the interpretation, like the word essential, need? So are the patients getting the same meaning as we as expert have thought of? Is there any interpretation problem or not? Is the questions, it is getting very heavy so that it is leading to a lot of respondent burden? Many times we attempt some questions and we think, yeah, this is really difficult. And if the question is very lengthy, most of the time we think that, oh, we are not going to respond to that long question. And then at the end, we tend to rush through the questions. So is your questionnaire, is it creating that respondent burden or not? And then in this also you check for the reliability and validity. We'll discuss tomorrow in detail about the reliability and validity. And then we see the response latency also. That means how much time that person is taking in getting the response, means what mental processing is going on, and in getting the answer, on reaching to an answer for a particular question, how much time that person is taking. So these all things we discuss or we test in the pre-testing. So like this was one question which I have taken this example of, that there was a SAGE handout on the difference between the pre-testing and pilot testing. So this was the question like housework. This question was asked, like, considering your work and commute schedule, would you say the division of your housework is fair? And these are the 5 responses. No, I do the way too much of the work. I do somewhat more than I should. No, my partner does way too much of the work. So can you identify which is the word which is not very clear in this question? Which can vary from one person to another person to a large extent.
Fair, ma'am.
Fair? Okay, very good. So maybe fair, it's not defined. I don't know what is fair. Again, regarding that housework also, it is very different. You can see that if a person is living, only two people are living in a joint family, with kids, without kids. So then you can say that housework definition is also not very clear. So you will ask these questions and then you talk to the people who are responding, like how they are getting it. And this is very essential. Many of us only write as a part of the project that we did pre-testing, we did pilot testing. But actually, we are not very much sincere into conducting this study. But this will lead the accuracy, this will lead a good data collection. If you focus some time on getting that pre-testing done, definitely it improves the tool and it improves your questionnaire, whether it is a scale or it is a multi-item measure. So if you don't do the pilot testing, then definitely it is a potential threat to the accuracy of the instrument. And the rule of thumb is you should at least do it on minimum of 12, maximum of 15 people. In the pre-testing also, the pre-testing can be expert-driven. That means you have developed this question with a separate set of expert, and now you send these to another set of expert. But again, I'm saying you because we also conducted few studies, and getting the responses from expert is not very easy task. You send it over the mail, and then you send the reminders, and then you talk to them personally also over telephone. You request them to give the answer. So it is better if you can find out someone who is locally or who is in your institute so that you can go and talk. If not, then again, these days there is a Zoom platform. There are so many virtual platforms are also there. And you can go with those platforms for this pre-testing. And then in respondent-driven, you can go to the patients or the actual subjects who will be there in your research, and then you can do the pre-testing. So this is the pre-testing. Now coming to the pilot testing, basically pilot testing, we call it as a dress rehearsal, mock run, or the dry run. So it is known as a feasibility testing. So you run the project to see the logistics, like how the interview will be done, how much time it is taking, coding, is it feasible to do it or not? Some analysis you do because you want as a rehearsal. You check the feasibility, you see the resources because you have to map out the budget and all other thing also. And you have to see the administrative procedures also, how convenient it will be. And then you run the entire project, because if the project is very big and if you don't do the pilot testing, then there will be a lot of, that's why you see that in big projects, there are a lot of protocol deviations. You have planned something else, and then you did not do the pilot testing. And then there was a switch, or there was a change, or there was a modification because a particular thing was not practically feasible in the field. And this is mostly in case of a large project, especially the community-based project. That is like one of the professors of pharmacology was discussing regarding the ICMR project. So we have also faced this issue. There was a task force study. We did not do the pilot, and because it said that the pilot has been done. But when we were starting rolling it out, we had a lot of difficulties, in the local setup regarding the people, their responses. And then we deviated from the protocol. We communicated to IC that the initial methodology, now there is some change in the methodology and some change in the logistics, the way we have to, do the testing and all. So that pilot testing, if you do the pilot testing, you will come to know regarding these nitty-gritty and the minor details which are there. And then you will be more confident in rolling out the entire project. So that's the pilot testing. So I hope all of you are now clear the difference between the pre-testing and pilot testing.
Ma'am, I want to ask something. If in pre-testing, we are also administrating to the subjects, in pilot testing, we are also administrating to the subjects, then what is the difference?
In the pre-testing, you are focusing on the tool, the construct, the items, their interpretation, the language conversion which you have done, the meaning of that particular item,
Okay,
or that particular word, which that person is understanding, and what you have devised as an expert. So basically in pre-testing, you are focusing on the
tool,
not on the process.
Okay,
And
thank you.
there you don't do the analysis also. There you only see the items and their interpretability, how much time that response latency which we talk in a particular item. And we see the respondent burden. Like if your item has got 60, if your scale has got 60 items, and if you talk to the people and they will say, no, we are not ready to fill that much lengthy question, then you will think the, okay, I can shorten it a little bit because it is creating a lot of respondent burden. So in that pre-testing, your entire focus is on tool,
Yes, ma'am.
accuracy, the items, the interpretation, the response latency, the time, all those things. In pilot testing, you don't focus on any of those things which you have already done in pre-testing. Here you are not going to ask from the people whether they are understanding the tool or not. Here it is basically the logistic. Like
Okay.
I'll give you one example. We were doing a project on one of the person has written a vaccine hesitancy. So there was a vaccine which has to be introduced. And in the community uptake, we were discussing it's regarding how the people will accept already in the UIP, there are so many vaccines. So if we introduce a new vaccine, so are people ready to take that? And if yes, at which part of line? Maybe at 6 weeks, 10 weeks, or all those technical detail. So initially it was a FGD. But when we started doing that FGD was getting converted into a group interview. So you understand the difference between the FGD and group interview. In group interview, the facilitator is talking to everyone, but the people are not talking to each other. And it was difficult for us to find out a place in the community. If it is a PHC, there was a lot of noise, and the recording which was there, it was of a very poor quality. Voice was not coming perfectly. And in that transcripts also, it was not very clear. So then we decided it's better to do a key informant interview and in-depth interview. And we converted all, after 2-3 FGDs, we have intimated to our IC that now we are resorting to the in-depth interview, because the quality of data which we got as a transcript, it was very difficult to analyze, and it was not feasible also. So that's why that was one example. So we could have done that earlier, and then we could have formed that. So that's why we call it as a dry run. So you do a little bit of it in the community to see the feasibility. That's why it is known as the feasibility study. Generally for small work, for thesis, it is not done, but for projects, which are maybe a multicentric project, or which are for a funded project, it is better that you do some part of it so that you can modify the rest of it. Okay.
Yes, ma'am.
So Manu is writing what should be the sample size of pilot study. So in pilot study, generally, there's no sample size. You can do it on maybe 10, 20. What you can do, I'll tell you. You can start your project as a project, and then after 10 or 20, that's why we always say that, analyze your result or see the transcript once your project, even the thesis starts, because then you can modify how the data is coming. So you can start the project after 10% of your data collection. You can sit and see those things, and then again for rest of the sample size you can modify. So maybe the initial, you can say, I have not seen any guideline. Maybe you can say 15 to 20, maybe 15 to 30, depending on the context. Like in our context, we have stopped taking the FGD after 2 FGD only. So and our sample size was 54 FGD. So we converted only after 2. So yes, Swati is asking, can we add data of pilot study into main study? So ideally, we should not. But if there is no major deviation, so pilot study is basically the feasibility study. So if you don't find any major change in your methodology, then you can include the result of your pilot into the main result also. You can have that. But if there is a change of something, then definitely that data will also change. But data in this case will not change, because that tool you have finalized. So you can have that. You can add the data of your pilot testing to the main result. Is it clear up till this point? So once you have done this, then we'll see break. So do ethical is needed for pilot study. So basically, yes, because if you are doing a study, actually you form your proposal like that, because you will write in your steps of tool that you will do the pre-testing, then you will do the pilot testing, and then you will start collecting. So that's a part of your overall proposal actually. And that proposal you submit. So once it is cleared, then you get the clearance for pre-testing, pilot testing, and the actual research. Swati, is it because you cannot do any research, especially those large scale research, if you don't have any ethical clearance. You need that. So basically, then what you do in the beginning, only you inform the IC that you are going to, you don't, otherwise what happens? Many times you will see the research data of the PGs. I don't know, many of you are mentor at your institute, and that's how we also see a lot of people, students, they will come after all the data collection. And then you will be like, how to, because you cannot go back again 1 year and ask them like you did wrong. So that's why we always say that, all the guides, they should see the data. And we have started seeing the data after maybe 10% of the data collection. Because if you see at the last, you cannot do anything until the time they have completed. So there will be a lot of error analysis and then measurement, all those things are there. So you should, so that ethical clearance though you get for the entire project. And then you do the pilot, because for pilot testing also you need the fund if it is a community based. So fund you will not get unless that is cleared by your ethical committee. Okay, Swati? So now after this, so do you want break of 2 minutes, all of you? So is this yes was for break or for, okay, so Dr. Neeraj is writing no. Any other yes or no? Ananya is writing yes. Rajiv is writing no. Yes. Oh, very difficult situation for me. So then I will continue, because then yes for understanding. Okay. Thank you, Swati. And these yes for break. Now what to do? So, okay, we can take break of 2 minutes. So quickly, we are here. Those of you, I will not talk for 2 minutes, and then I may start after 2 minutes. Yes, Dr. Devjani, it's right. It's half an hour. No, we can continue for beyond 5 also. We will continue like 15 minutes beyond 5 also. Those of you, because otherwise today's content will not be completed. Because I don't want that this should continue tomorrow. Tomorrow we will start with the reliability and validity. Okay, thank you, Devjani. Thank you. So we can start. So after this, we'll see how to do the content validity. We'll see tomorrow, and how to check for the internal consistency. So I have got the final version of the translated scale to measure my construct of interest. And if I don't have, like, if you can recall that step, if I don't have any scale to measure my construct of interest, then I will have to go with this development process. And then I will have to justify the need of my measurement. So how will I do that? So these are the steps. So the first step is to establish an expert committee. And I said that there are challenges in establishing this expert committee and getting the response from them. But again, if you have to develop a scale, you need to go through this step as well. And then the second step is to identify the dimensionality of the construct. So first step is to identify the construct. So construct, I said that there are two things. There is a conceptualization and there is a operationalization. And in this case, you may need the help of a theorist also. A theorist, like a person who is working on the theories or the theories in the health system. So we cannot have a good measurement without a conceptual or the operational clarity of construct. So like if this is a construct, prejudice. So if I talk about this word prejudice, I have got certain image in my mind if I see this word. So there can be like, this is one question. So yes, can someone read this for me? I can again see Ananya at the last. Ananya,
Yes, ma'am, I can read.
thank you.
If someone says bad things about other racial groups, is that racial prejudice? Number 2, if women earn less than men for the same job, is that gender prejudice? 3, if doctors believe that they are superior to nursing staff, then it's professional prejudice. 4, are there different levels of prejudice, such as high or low? Answering all these questions is the key to measuring the prejudice construct correctly. The process of understanding what is included and what is excluded in the concept of prejudice is the conceptualization process.
Okay, thank you. So in this case, you can see that this prejudice, if I talk about this conceptualization, in what are the various types of prejudice? So you can see that there is a racial prejudice, there is a gender prejudice, there is a professional prejudice. So there are various components of these prejudice, and I should have items regarding all these components. Then only I can measure prejudice as a whole. So remember, we were talking in that reflective one. If you can recall that model where you people were asking me regarding giving example of that reflective scale and the causal formative. So like taking this example of prejudice. So you can see prejudice is a one major construct and it has got different subcomponents like racial, gender, and professional. So these are the three factors of that broader construct. And then there will be item measuring all these various component of a larger construct, which is prejudice. So these were the individual item. And if it is a reflective one, the direction of arrow will be from the prejudice towards the item. And the error will be at each of these items. Okay. Again, socio-demographic status. So if we define conceptually, then you can see that it should have like social status, the number of family members, the earning capacity, and etc. So I'm not going into the questions because I have to finish this by 5 so that you people, there is an activity, breakout room activity for 15 minutes. So we'll have a breakout room at 5 o'clock. So constructs needs to be translated from the abstract concept, that is the mental idea or that latent variable which is unobservable, to something which is measurable or the observable. Remember, we talked about there is in psychological domain which is hidden, and then there is something which is visible or which is measured. So now coming to the operationalization, how to define this operational definition. So this conceptual definition, it only provides the platform again for the operational definition, because you need to define it operationally. Like you said, fair. How to define that fair? I said that housework. How to define that housework? So you need to define that particular item or the construct. So if we use the items to operationalize, and we are measuring the construct through these items. So I'm skipping this. Now coming to the second. So this was, I have the established expert committee. I have identified the dimensionality of the construct. So now what is this dimensionality? Like I said regarding the prejudice. So they were having 3 dimensions. Now coming to the questionnaire format. This is the third step, determining the questionnaire format. So which type of questionnaire I am going to use, whether it is I will take the interview, or whether it will be the self-administered. So it depends on the literacy of the person. If the person is literate, can read and write, then you can administer, you can give the, it can be a self-administered. If not, you can take the interview. This is the determining the questionnaire format. Now coming to the fourth item, which is the determining the items format. So coming to this items format, generally we have in all these type of scale development, there are various type of scales, but the most commonly scale which we use is a Likert scale. So now a few words regarding the Likert scale. So if we talk about the rating scales, there is something known as the binary scales. So what are the binary scales? Basically, these binary scales are the nominal scales which consist of binary items, like only 2 possible values. Like in case of knowledge, whenever we measure knowledge or practice, generally we answer as yes or no, or true or false. But I said that most commonly we use Likert scale type of measurement if we are developing a scale or if we are measuring a construct. Now, what are these Likert scale? So basically, in this Likert scale, we have a STEM. STEM means like simple worded statement. And how we have devised those statements? So these statements are devised from an expert committee. Remember, I said that when you have that expert committee, you devise through the key informant interview, through the clinical observation, through in-depth interview, all those qualitative statements. So you take those items and then you form the responses. And then respondent have to answer whether it is a 5-point scale or a 7-point scale. It is up to you. Generally, we use most commonly a 5-point, but you can use a 7-point, 10-point, 11-point, depending on your need. Generally, it is said that larger the understanding, larger the literacy, the level of scale can increase. If the person is not very literate or understanding is not that much, then you should not have a 11 or a 13-point scale. So generally in India, we restrict ourselves to 5 to 7-point scale, and it is like strongly disagree to strongly agree. But in West, you will see in London, maybe in British and Sweden, they generally use scale up till 11 point, because they can clearly delineate what is 9 and what is 11. For us, if you ask from a person, even for a 5-point scale, they will find it very difficult to say whether they strongly agree or they strongly disagree, and so on. So coming to Likert scale, I said that it can have a 5-point, 7-point, or 11-point. And again, one thing, I said initially when we were differentiating between the multi-item index versus a scale. So in multi-item index, you can have a different length of measurement for each of those items. But in case of a scale, it is preferable that you should have the same scale length for all items in the scale. Are you getting my point? if there are 9 questions like PHQ 9, so for all 9 items, I will use a 5-point scale. I will not do like for first 2 questions, I use 5, then 7, and then 11. So Dr. Neeraj is asking, is it necessary to use odd numbers? So yes, odd number, because then you see the middle. It is not necessary, right? Many times you will see that you leave in between, and that it is a continuous number like 5, 6, 7. Like VAS, you will say it is a 10-point scale. So it is not a odd number, it is a even number. So you will see that many times these days, numerical rating scale, there is something known as the NRS, which the anesthesia people and people who want to measure pain, they are using it. So it's a scale from 1 to 10, and there is 0 at no pain at 1 and very high pain at 10. And then you give a number to it. So basically what they have done, instead of ordinal, it's now more of a continuous. Again, it is in the form of a discrete. It cannot be like 1.2. It is in the discrete form, but it is not necessary that it will always be in the odd or even. It can be anything. If it is on a continuous scale, you can have a 8 point. But again, traditionally, we see that it is 5 point, 7 point, because in the median, someone has, Vikram has written median. Basically, when you want to say neutral, or like I'm not either towards the higher or lower, and if you have got odd number, then being in median is easy. Then I can say that if the mean score, if it is a 7-point scale, and if largely the mean score is like 4.2, I can say that most of the people are neutral on this statement. So interpretation is a bit easy if you take it in the form of a odd, but it is not necessary. Dr. Neeraj, did you get your answer? Okay. So now this respondent, they are confronted with the rating scale. They, whenever they read this rating scale, that mental process, no, there is a switch on of that mental process, and then the respondent start thinking it. So they should have something, a process going on, and then they respond. So conditions should be met in order for that rating scale to be work effectively. So what do we understand by that? That you should give ample time to, you should not be in hurry. You will see that I have seen PG students asking questions and they are into hurry. Like they want immediate answer from the respondent regarding this Likert scale. So you should give time to think, because it is not very easy to answer. So points of audit should cover the entire measurement continuum, and it should be ordinal, like I said, and each respondent should have a understanding and meaning of each of those items. And that's how we did that pre-testing, which we discussed. So again, I said that value, there is a value of adding more point to the rating scale, but it depends on how refined the people's mental representation of the construct are. And I have given you the example of maybe Bihar and Sweden. So the same scale and the rating points cannot be used for a person who is from Sweden and who is from Bihar, because the mental abstractions and the capacity and the refinement of the people, psychological domain is quite varied. So you should see that perspective also whenever you try to have a number of points on the rating scale. Again, I said that in the rating scale, so yes, Dr. Devjani, you should not have less than 5. Because then many times you will see that you calculate a mean score and you see the correlations and all. So basically what happens, that correlation generally we do if there's a continuous, we have seen that. So if your scale has got 5 or 7 or 11, then generally that ordinal scale is treated as a continuous variable, and then you can perform all that analysis, because you will see that it is all that factor analysis. It is a type of a regression analysis, and you calculate a regression coefficient, which is the loading. So if you take less than 5 as a response, then you may not do all those analysis on your scale. Definitely, you can do that reliability analysis, probably. Even for reliability also, like to calculate Cronbach alpha also, if you have a 5 point, it's better. Then otherwise you have to go for some other analytical methods. So that's why we want our response number to be treated as a continuous scale, because all the analysis like factor analysis, confirmatory, exploratory, and then the reliability, that is valid if it has got 5 or more, because it treats those scale as a continuous. And is there any acceptable lowest? So did you get your answer, Debjani? No, binary responses are not eligible for EFA or CFA. They are not.
Yes, now it's clear. Thank you.
Okay. Even for Cronbach alpha also, there's another test which is some KR20.
Yeah,
You
yeah,
cannot,
yes.
you cannot do that this thing on
We
a
cannot do a
Cronbach
factor
alpha.
analysis with that, but I think so Cronbach's reliability can be done. with the binary.
Yeah, you cannot do. So that's why if you've got at least 5
Mhm.
for all those validity and reliability and the factor analysis, that much is needed.
Thank you.
Okay. Now, coming to the clarity of the scale points. So for rating scales, I said that you should have those words like strongly agree, agree, neutral, disagree. But again, if you increase a point, then the meaning become less clear. Like you will write strongly, strongly agree, and strongly, 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 strongly agree. What will you write? So that's why I said that it is now, generally you will see that we convert it into a numerical scale, where that if it is as 11 point, you can see that the smallest, it is strongly disagree, and then there is a strongly agree, and then all intervals are there. So if like somebody has marked here 3, so it will be 3, and then you don't like give those responses as a like in a word. It is just as a point scale. So it is considered as at an interval scale, not as a ordinal. Now coming to the type of Likert scale. So Likert scale, the items for which we devise these Likert scale. Okay, so again, there is a question Dr. Vidyarani is asking, can Likert be converted into binary scale, agree and disagree? You can convert it in agree and disagree, but then there will be limitations of the analysis. You can do the content validity index, but I said, Dr. Vidya, for you should go for some other analytical approach if it is a binary. Again, if you see the responses, and if you think in our psychological domain, it is not always agree and disagree. That's how this Likert was developed. Because many times you will see that there is a shade of these agreement and disagreement with any statement. It is not always black and white. So there will be loss of data also. If you like if you convert these Likert scale into binary scale, there will be a loss of information in doing this process. Of course, you can do that. It depends on your objective. But definitely, it will lead to some loss of the information while doing this process. Okay. And then Dr. Debjan is asking, does direction of value have any impact? So yes, Dr. Debjani, generally, it depends. And that's how comes the role of reverse scaling. If your statement is positive, then definitely the lower scale you mark with the disagree and the higher you mark with the agree. If your scale is like negative statement, we'll see that. Then if you have not reverse scaled, then what will happen? It will lead to you will see in the correlation, it will have a negative correlation. Because if the question is positively framed, and we'll see that in the health, quality of life also, you will see that. There are some questions like if I see that I feel sad most of the time and I feel happy most of the time. So for happy, my answer would be like most of the time. And there is a example in this question where you will see that this direction has got an impact, because in analysis, you will see that there will be negative correlation between these two items if the direction is opposite. Okay. So this we will see later. This is only regarding the analysis. So basically in analysis, we will see that if there are items, it is you can treat that an ordinal scale, or you can treat it as if you treat it as an ordinal scale, then you can make a 2x5 table, and then you can perform like chi-square test or any other test like a categorical variable. If you treat it as a continuous, then you can apply a t-test or an ANOVA depending on the number of groups. So this I'm skipping. So we have discussed like establishing an expert committee, identification of construct, questionnaire format, items format, and then items development. Now for item development, I said that basically you should do an in-depth interview, literature search, focus group discussion, clinical observation, and theory. So tips for developing the item: you should use short and simple sentences, and you should ask only one piece of information at one point of time. Like in this question. Can someone read this question for me? Dr. Shraddha? Or Dr. Devjani?
Have you had headache and fever in the last 24 hours? Identify the problem in this item. Ask for only one piece of information at a time.
So what is the confusion in this question?
There are two entities which are being looked into in the same
Yes.
question.
Which
So
one
if
to
yes answer
identify?
is for headache and yes and no it's for fever, the person has no way of doing that in one shot.
Very true. Very true. Perfect. So 2 questions at one point of time. So then the person will be confused like you explained. Very good. Now, can you identify? Yes, who can? So Dr. Poonam is writing. Yes, good. Dr. Priyanka is also written. Dr. Satyanand is written last 24 hours. Yes. So anyone, Dr. Poonam, can you read this?
Yes, ma'am. In the last 24 hours, how many times did you not have dizziness? Identify the problem in this item. So
What is the problem?
did you not have looks complicated?
Yeah.
It can be easy.
So generally, we should avoid negatives.
Negatives.
Yes. Dr. Satyanand, can you read this?
Have you had headache before? Identify the problem in this item.
So before, what is the problem in this item?
It is hypothetical, madam. Something. It's not.
Yes, it is saying before. Yes, Dr. Neeraj is right. Before when? Last 1 week. Last time is not specified. Very right. Yes, Dr. Samina, can you read this?
Have you had neuropathic pain before? Identify the problem.
Yes. So what is the problem with this question?
Neuropathic. They're asking.
Yes. And again before. So both the terms, time is not specified, neuropathic, technical term. So this we have discussed, pilot testing. And it's a repetition. So if whether you have got a translated scale or you have developed a new scale. Yes, so Dr. Ananya is right that common people cannot understand the technical term. So whatever your path is, whether you are already using an existing scale, modifying some of its item, adding some of its item, translated it, or you have developed a new scale, you in both ways you have to do a pre-testing, you have to do a pilot testing, and then you pre-testing, and then all those reliability, validity, and factor analysis, which we'll learn tomorrow. So now we have discussed about this sample size for pre-testing, that it should be from 12 to 50. Lowest is 12 and largest is 50. This is the dimensionality of the construct. So now see these questions. It is a general health questionnaire. There are total of 12 questions. So if you see these questions, what can you see? Is it if I ask about the dimension? So read these questions. Yes, can someone read these? Maybe I can ask, or you can just if you can see and answer the dimension, whether it is a single dimension or whether it is a more than one dimension. You can type in the
more than one dimension, I think.
yes. Right now it seems. Again, I said that when you do the factor analysis, then you see that whether it is single, how the people are perceiving, right? Because you see, even if somebody has done a factor analysis in Chinese population, the results may be different in the Indian population because scale ka context is regarding that population. So again, it is definitely not, it doesn't seem to be a single. Again, if you see this WHO quality of life brief, the classically, is it a single domain or is it a more than one domain?
More than one domain.
Yes, agree, more than one domain. So in the what difference you noted in the structure of both questionnaire? This one and this one. Domains mentioned, yes. Here you can see that already domains are mentioned. Whereas in GHQ, they have not mentioned any domain. They've just given overall. Again, if I ask this competency of a medical undergraduate, so theoretically, is this a unidimensional or a multidimensional? Yes, so Adarsh Jodh was right that don't speak section. Dr. Poonam, Priyanka, Vikram, Supriya, Satyanand. Yes, so it is a multidimensional. That's why we say that attitude, ethics, and communication. So do you think that the attitude, ethics, and communication can explain all the variance in a competency of an undergraduate student? Can these three domains explain all the variance? So yes, right. So now, I think I am skipping. This was one example. And then I have to give you one exercise. So this exercise is like developing an item. And it has been shared to you in the WhatsApp group and in the chat also. So there are two activities now. Dr. Naveen, once I am finished with giving the instruction, like when I stop giving the instructions, please open the breakout room and link also share in between. So there are two activities. So in the first activity, you have to develop the item for a construct which is known as the statistical anxiety. So statistical anxiety I define is there will be items. So you have to select statement or item related to statistical anxiety. Okay. And then in the activity 2, we have shared one tool with you. And in which is a 51 item tool. And you have to form as a team, like which item do you think that it should not be there? You want to modify it or you want to delete it? Slide, do you want? This I'm skipping. So this is the activity. So you wish to measure the level of statistical anxiety among medical postgraduate students.